دلوقتي موعدنا مع أستاذ الدكتور حسام زيادة طب الأزهر هيقدم لنا توك ليزرز إن كراتوكونوس The Rule of the Role.
السلام عليكم ورحمة الله وبركاته. بسم الله الرحمن الرحيم. Yeah, first of all, I would like to thank gratefully Professor Ahmadi for the kind invitation, and my special thanks to my dear brother, Dr. Amr Munir, and my dear sister, Dr. Angie, for their invitation and for the great organization of this meeting. Actually, we are still asking ourselves about the lasers in cryoconus. They are forbidden procedures, or we can refine the use of the laser in patients of cryoconus to benefit from it. I have no financial interest in the general concept. Like the cryoconus is a weakness, so the laser will ablate and it will increase this weakness. But the weakness needs actually an adding of a power rather than decreasing the power. So the surface ablation on a cratoconic eye may sound unorthodox. But the actual goal of our treatment using the topography guided software is to normalize the corneal surface and to improve the best corrected visual acuity. This is a therapeutic procedure. It's not a refractive one, aiming at a significant improvement in surface regularity and the best corrected visual acuity. So what's up? And what's going on in these techniques? We need to set up the rules of the role of the laser treatment in cryoconus. First, laser ablation is a definite calculation. So we can do it strictly in the cratoconic patient, selecting the suitable corneas for a good mean. Otherwise, I will agree with you that's a matter of malpractice, and you will deal with it as a matter of chat. The compensatory co-effect of the cross-linking is mandatory in such techniques. So please don't deny the role of the laser in cryoconus and saying, as in this photo, ما هذا بحق الجحيم. And related visual deterioration, and also don't abuse it or cross the borders and making the laser in cryoconus as a bless treatment. Yeah, don't dry and don't bless. Going again to the back, the Essence protocol, which was introduced in the 2011, despite limited, but was brave. It had opened a window, not a door. A lot of terms should be known and the condition should be available. Introduced into two forms, simultaneous, both together in the same session, or sequential with high recommendation of the simultaneous procedure as reported by the authors. Again, the same paragraph. It's a therapeutic procedure, not a refractive one. The protocol actually was partial PRK, topography guided, mustn't exceed 50 micrometer or microns ablation depth, and the 5.5 millimeter optical zone. Mitomycin application 0.02% for 20 seconds, then cross-linking with a conventional technique. And in my paperwork, I have modified it to be a topography-guided PRK, but limited with surface regularization, not including the errors as much. Mustn't exceed 40 micrometer, not 50. I'm going to be more safe and making like that. That's usually made by the oncosurgeons. They are excising the tumor and taking what's called the safety margin around. So I'm dealing with the cratoconic patients and even the normal patients with high errors to ablate with a laser, giving myself a safety margin all the time. According to the residual stromal bed, the PTA, I usually going before the limit. Like in the PTA, I think the limit is 40%. I'm putting my cutoff on the 38%. And so, no mitomycin application in my technique, and the cross-linking is with the accelerated technique, not the conventional one. And I will show that later why I choose these techniques or these modifications. Priority is for treatment of the irregular surface at and around the cone, not for the refraction. Oppositions all the time, and many surgeons and many literatures published to oppose this technique. And I know my professors from Egypt, they are denying all the time to do this technique by this way. But I'm insisting to continue doing it with some recipe modifications and waiting for the results at the end. Because it's an aggressive procedure, unpredictable, unsafe regarding the terms of epithelial defects and infections, also the haze formation, progression after short time, but actually the collected data and have shown by many colleagues were not accurate at all. I have done 244 eyes, 6 years with follow-up up till now. I will show that I have found. What about the contour? It's related to this technique or not? It's topo-guided ablation profile with a force analyzer. And I will show very quick, because of the sake of time, the calculation of this RC. If you look here, you will find that there is difference between the maps before and after ablation with the forced analyzer. In the contour revision, you will find that the calculation included a very minimal refraction with the all attention to the high order aberration, the surface of the cornea, and they calculated the anterior and posterior astigmatism of the both corneal surfaces and give the minimal part of the astigmatism, which was, instead of -3, they put just -1.2. And here you will find the difference in these two maps. There's no pointer, but here you will find that there's inferior steepening after correction with the contour revision. We will find that there is a great difference between this map and this map on the surface with a very minimal ablation depth. There are many trials showing the satisfactory results regarding the Athens protocol. By Kohler et al., the topography-guided PRK was used to treat 11 eyes of 8 patients with form-fused cryoconus, statistically significant reductions in the manifest refraction, corneal irregularity, and high-order aberration occurred in this study. There was no loss of the best-corrected visual acuity, and 7 eyes gained better best-corrected visual acuity. After laser treatment, all eyes had a central thickness more than. This is the issue. You have to choose a thick cornea to do that, not that thin, to leave behind 450 micrometer or more after ablation, indicating that these patients were carefully selected. This is the issue. Also, Basinamo, 18 eyes with cryoconus, 7 bilateral and 11 unilateral cases, underwent the same technique, and finally, the same satisfactory results have been shown by this. Also, Albans et al. Longer-term analysis of 45 eyes with form-fused cryoconus and mild keratoconic eyes after this technique, and with a 10 years follow-up. Post-operatively, 32 eyes were followed for 5 years and 9 for 10 years. Take-home message is that these patients were carefully selected. The mean age was 4 years. Pre-op was 2040 or better. Their mean key reading 50 or less diopters, and they were stable for 2 years pre-op, and no patients less than 25 years old, and no signs of keratoconus upon the slit lamp examination. At 1 year, 7 eyes lost 1 line of the best corrective visual acuity, but 16 gained 1 line. In this literature or in this study, I can show you now the exacerbation of the keratoconus as done by Ortho Milquez had published the case of 22 years old French patient with mild preoperative. Here I will show what I have talked about the selection of the patient. The inaccurate data may be against without an evidence regarding this issue. If you selected the improper patient, you will get the improper results. Actually, I was listening to a presenter who were against the Athens protocol itself. And finally, I have asked him just one question. These cases was done with the topography guided surface ablation regarding the high order operation or full PRK. He said full PRK for correction, full correction of the error. So these patients are out of the plan, are out of the protocol of this technique. Again, to the Athens protocol, many names but the same concepts as shown in this photo. Fin ودنك يا جحا, the same concept. Here I will show the difference between the customized cross-linking and the Athens protocol technique. You will find here that cross-linking will stabilize the cornea, but there is no change in the surface actually. But down you will see the difference between the inferior steepening in this map before and after the topography guided ablation and regularization of the surface, followed by the cross-linking. It's totally different. The aim here is like this photo. Both procedures together will increase the stiffness, will increase the power of the cornea. So regularization followed by stiffening of the cornea, so you will be safe. Finally, the rules, tissue removal should be strictly limited. I prefer to be less in order to be safer. Topo-guided ablation, like the customized, not optimized TCAT, not FCAT on Allegretto, more likely with irregular cornea and astigmatic errors is not the aim. Sequential or simultaneous, I will skip it to show it after. And my own experience after 13 years with Athens protocol, the same modification of mine. If in case in the form first keratoconus or the grade 1 keratoconus with error of refraction, mixed or cylinder, ablation depth shouldn't exceed 45 microns, provided that the thinnest location is 500 microns or more. But if the thinnest location is 450 to 500 microns, the ablation depth should be 30 microns or less. I do the same for a regular corneal surface using the topography guided map without correcting the error to regularize the surface using the available ablation depth. I usually do surface ablation plus cross-linking at the same day with no delay. Epithelial removal depends upon epithelial thickness map to decide manual removal or trans-PRK removal accordingly. If regular epithelial map or almost equal, I do trans-PRK. If there is a big difference between the epithelial thickness map all over the cone, I prefer to remove it manually because the irregular surface will leave behind a regular epithelial. I know, I'm sorry. Can I conclude in 1 minute? Ablation should be customized considering the irregularity But topography guided, wavefront guided is not different actually, with both of them with the same, almost with the same. With the new technology of the MS39, we can know the epithelium, stroma, and Pullman's configuration separately so that the treatment plan can be designed more accurately. Then what about complication? Number of cases, 244. Stability of the cone was in 98% of patients. Delayed epithelial healing was just one eye. Infective keratitis, just one eye as well. But this patient, she lost the bandage contact lens and she put it again with the contamination of the contact lens, and she had a fungal keratitis. But in the late epithelium healing, I'm using a potent antibiotic and aggressive steroid from the day one. About the central haze was just 6 eyes, which may be found with a regular PRK. It's not that of that. The p-value was highly significant. So we can state that the cross-linking could be a refractive surgery because of the minimal change as reported by Canelopoulos, that there is change of around -1 to -1.5 diopter after a good cross-linking. So you can use only cross-linking in such cases if they have a minimal errors. And about the customized cross-linking, I don't believe in the customized cross-linking up till now. I have done many cases according to the Farhat Hafizi reports, but I didn't find actually the same results I have read. And thank you so much.